I have one downstairs. So she might be. I know, but that's what every girl knows. Wait, are you 37? What are you? Cancer. I'm a Cancer. I like that. My birthday was fine. I want to make sure everyone knows. I'm also a Cancer. We have a lot of. I'm allowed to say this. We have a lot of Cancer. Dale's a Cancer.
I have a Cancer.
Dale's a total Cancer. Cancer. Oh my gosh. Yeah, it sticks. What are you?
Okay. Yeah, it would be more fun to talk about zodiac stuff instead of the disease, but the illness. It'd be more uplifting. But we are going to talk about cancer. So we only have 50 minutes and there's 40 slides. And so we're going to try and get this through. I do want to make another recording though of the substance misuse PowerPoint, just so you guys have that. And so if I happen to not get through this whole deck, I'll start with this one and then kind of bleed it into the substance misuse one. So but I'm thinking we should be able to get through this. I'm pretty sure. So this is chapter 50 in Darby and Walsh. And these are, why isn't it advanced? Oh, I'm on the wrong thing. Hold on. Sorry. Hold on a second. Okay. Here we go. These are the objectives. So you can read through those on your own. So just an outline of what we're going to be going over today. We're going to talk about some terminologies and risk factors and signs and symptoms in the umbrella term of cancer. We'll kind of focus a little bit more specifically on oral cancer, just because that's more relevant to us, obviously. And then cancer therapies, which a patient could present with any number of therapies and have oral manifestations from those, or just some kind of a, tiredness, psychosocial depression, any kind of, they might, bring those things with them to the appointment. So it might not just be something that you see in the mouth, but so we'll talk a little bit about the different therapies, management of the oral complications. This also, I feel like, kind of overlays a little bit with the palliative care, when talking about like the mucositis, maybe was a little bit more thoroughly explained in the palliative care PowerPoint. So you can always go back and review it. A lot of these topics kind of overlap each other. And so I might hit something harder in one thing, and then I'm like, well, it applies just as well to this topic, but you can kind of use them all collectively because things do kind of overlap. And then we'll just go over the before, during, and after care for a patient who's going through cancer treatment, and then just look quickly at what's in the handbook or the clinic manual. So why is it in this information important? Well, like I said, cancer, the likelihood of you seeing somebody in your chair who is either going through cancer, who has had cancer, or maybe their family member has cancer or is going through cancer is extremely high. I mean, cancer is just very prevalent. And so the chances of you coming across that, and even if you're just discussing something, they might be talking to you about their family member that's experiencing salivary dysfunction or something like that. And then you can just help them. So you're gonna encounter this quite a bit in different severities. Some people might be going through cancer treatment and be doing great. And I mean, I remember seeing, she was like 91 years old and she had a lymphoma, I think. And she went through 91, she went through a year of cancer treatment. She lost her hair, she got a little tired, but boy, she came back and she's like, well, I did. And I mean, I'm just sitting there like, you are just made of some substance that's incredibly strong, because after all of that treatment, she was still she recovered quite well. So you're going to see all sorts of patients in your chair. And like I mentioned, not just the oral manifestations, but sometimes they come with psychological, that being overwhelmed from their diagnosis. So their OHI suffers because of that, or they or scared, or their doctor is saying they need to have everything treated. So, there's going to be all these reasons and stages that you might see a patient. Okay, so some terminology here. I don't think I will necessarily read off everyone. These are just kind of definitions. So just go through this. Understanding cancer is abnormality of unrestricted growth of cells. We kind of know that. Benign tumors. Somebody might have a growth, but it tends to be like the same tissue of wherever it is. So that's, what makes it more benign. But a malignant neoplasm would be something that oftentimes it's atypical or dysplastic, may not resemble the parent tissue. So our patient, you or whoever, that we don't want the malignant neoplasm. A benign tumor might not necessarily be as critical of an issue. Metastasize is that's when the cancer spreads through the body from one site and then it heads off somewhere else. Oncology, study of treatment of cancer, and oncologist is the physician who specializes in cancer treatment. So risk factors for cancer are kind of varied. There's lots of different things going on. It could be environmental, so chemical exposures. Radon is that gas that seeps up through the ground. Radiation from a number of different sources. The sun, if we get too much sun and we're kind of predisposed, it could get skin cancers. Hormones, there's the increased risk with certain hormones being prescribed. Asbestos is something they used to use. So, they've found through the time, that, we always sprayed this chemical on our plants and now it's a big, carcinogen. Don't use that anymore. So a lot of times we kind of figure stuff out, but sometimes we know things are carcinogens and we just kind of keep on using them. So be your own best advocate when it comes to that kind of thing for environmental exposures. Behavioral risk factors such as tobacco use, alcohol, just lifestyle in general, people, poor nutrition, inactivity, overweight, higher risk for cancers. And then we also have the viral component too, especially HPV and oral cancer and cervical cancer. So we know that's can increase people's risk. So carcinogen just means cancer causing. In the US, only heart disease causes more deaths in adults than cancer. Oh, that's no good. Okay, so early signs and symptoms of cancer, basically kind of look for, I wish that I had found it and put it on the PowerPoint. I'll probably look for it, but there's like a short phrase or a short saying that it kind of highlights, things like all these things. It says it in kind of an easy to memorize kind of way. But basically, if you have any changes in your bowel or bladder habits, and sometimes they also talk about, other things too, like bleeding or color and different things like that. Non-healing sores, unusual bleeding or discharge, thickening lumps, indigestion, difficulty swallowing, obvious changes in warts or moles, and a nagging cough or a hoarseness. So all those can be kind of some signs. Yeah.
Oh, yeah.
Are you, is that what it spells caution?
Yeah.
Oh, I'm like, I don't even know what you're referring. I'm like thinking I misspelled the word. I'm like, what? So that's.
Not.
Oh, so I kind of have it here, but not quite. Oh my gosh, I'm writing it down and now it'll remind me to change it on the slide. So caution. Okay, thank you. Very good. Oh, you guys are just so helpful. Okay, that's awesome. So there's been a rise in oral pharyngeal cancer. It used to be, we always said, oh, males over 65 or something, they're the only ones that ever get oral cancer. And for a long time, it was more or less true. But the age for oral cancer has sort of gone down. We see it happening more in people under the age of 65 for sure, and men and women both. So we relate that to the human papillomavirus or HPV. And the location for that is in the throat, back through to the tongue, soft palate, sides of the tongue, and the tonsillar pillars, all of those areas that we check when we do our IO. Some early signs and symptoms of oral cancer. Again, we're checking the lateral borders of the tongue, ventral surface of the tongue, floor of the mouth, oral pharynx, but we specifically are looking, my doctor used to always say lumps, bumps, and anything. He'd always ask his patients, any new lumps, bumps, or sores? He'd always say, because, you know, usually patients will have some kind of a awareness if something like that has changed in their mouth, but not always. And sometimes they're not looking in the specific high-risk areas that we know are important. So it would have to be something that was kind of in their more direct view, but we pretty much are looking for swelling, lumps, growths, and a lot of times it's painless. I had a patient when I was living in Arizona who had a massive sore on the back of her back lateral border of her tongue. It was big, and she had let it go for so long because she was afraid. The minute it didn't like heal up, she just kind of wanted to shut down and pretend, but it wasn't that painful. And to look at it, you'd be like, how did that not hurt? But it just didn't hurt. And so she just, and I think instinctually, you know, like that doesn't look right. And some people just would rather just, you know, try not to pay attention to it. So after she left, actually, I think by the time she had come back, either by the, I can't remember now, because this was this was like 2005. So it's been a while, but either right after she left or she had just come back from seeing a doctor that had said, you need to start moving forward with this. And it was oral cancer, it was squamous cell. But anyways, patients will notice induration, so hardness. So it could be erythroplakia or leukoplakia, sores that don't heal very well after 10 days to 2 weeks is kind of our standard. Repeated bleeding, things that just keep bleeding. And then of course, if they're having some kind of difficulty swallowing or hoarseness, something could be farther down their throat that they just can't see. And then 9 out of 10 malignancies are squamous cell carcinoma. So that's the most common. If it ends up being malignant cancer, it's usually a squamous cell. Okay, so just kind of out of a practical question, when you guys think about how long your appointments are here and how long it takes you to go through everything, and then you've heard probably from patients and from instructors who come in from their private practice, and you hear this in the, you know, over and over again, the first thing to go when you're running short on time is a really thorough EO-IO. So before you get into that world and into that kind of place, what can you think of as some ways to navigate that, to actually keep that as part of your routine? Yeah. Anybody else? Yeah.
If you're like really worried about time, you could do your EO while you're kind of going over oral hygiene and stuff, and like asking the patient questions about like what they're like doing for their oral, like oral home care and stuff like that. Kind of combine the two.
Yeah, I think that's good too, combining. Anybody else?
Probably rather than sit down, I mean, the second that you hold the areas that are symmetrical, and that's what I would start looking at. And set them down in medical distance. That'll help.
Yeah. And you guys will get, I mean, some of it happens out of necessity, and just hopefully you only take it so far, but you'll keep going faster and faster, and you don't get to the like, okay, I'm going down, but you know, and like now I'm here. Instead of being so like slowly methodical, you start to just kind of do a thing where you're just like rubby rub, okay. And then you look like, as you're putting on your patient napkin, if you have an older man in your chair who's bald and you see all these spots, but he's got one that looks a little bit like, whoa, that doesn't look like a great spot. You might say to him, hey, have you had that checked out? It's for possible skin cancer. And then, oh yeah, I go to my dermatologist every 6 months, so these things can kind of fold into your appointment. And like Lauren said too, a lot of what's happening intraorally, a lot of times you can do that, while you're cleaning their teeth, but never let you kind of slide into this complacency. Always pull out their tongue or have them stick out. There's certain things that you won't see from just a regular cleaning, but it's so true. You see a lot of that stuff anyways. Yeah, it's super common, super common. I mean, you will be the first one likely to spot something in many, 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 many people. And if you spot it, you'll spot it early. And that's just priceless. So the 1-year survival rate for oral cancer is 84%. 5-year survival rate is 61%, but that's with early detection. So, and of course, the survival rate increases, but also the disfiguring surgeries that might come. Also, that's going to lessen the likelihood of those disfiguring surgeries. So cancer therapy, so the goal, of course, is to remove and destroy the cancer cells, but also a lot of times healthy cells are, taken out and with that therapy. But types of therapy would be chemo, bone marrow transplant, radiation, surgery, and then sort of a subcategory. There's the blood transplant, the hormone therapy, immunotherapy, target therapy, stem cell transplants. So there's lots and lots of different, and this can become very, this is why we're not the experts in this. You're not going to always, a patient might have a laundry list of things that's happening to them, and they may disappear from your office for a year and a half while they're in heavy treatment. And then of course, biopsy, the surgical removal of all or part of the lesion. Treatment not only targets cancer cells, but normal healthy cells can be destroyed as well. Say it again.
There's the bold, the last slide. There's the bold.
Yes, yeah, those are like your major cancer therapies. Yeah. Okay, so chemotherapy is of course using various drugs. A couple negative things that will happen for a patient on some kind of chemotherapy is they're going to have increased likelihood of sepsis or blood infection, periodontal disease, pulpal disease, pericoronal disease. So it's just going to increase their likelihood of infection just in general. Yeah. It could happen with somebody that is significantly immunosuppressed. So that is when you would probably have to reach out to the doctor and find out. And they could have said, oh, you're going to the dentist, take this antibiotic. So it can happen with somebody who's significantly immunosuppressed. So infection, also a result of the complications, the myelosuppression, so the suppression of the bone marrow, not producing the white blood cell count. So other complications, patients, obviously we always think of things like hair loss. So alopecia is a common one, but they can have photosensitivity. Their skin can be more sensitive to the sun. They can burn. These are different acute toxicities of the drug. So nausea, vomiting, you hear that a lot. Patients who are having these acute toxicity, but then other things like their platelet levels can decrease, so they have bleeding or hemorrhaging, and then electrolyte imbalance as well. Okay, so patient undergoing a bone marrow transplant, this is used to treat hematologic diseases. So this is probably for specific cancers such as aplastic anemia, leukemias, lymphomas, neuroblastomas, and the other ones that are here, some solid tumors as well. So the process with this is basically what they do is they pretty much kill the individual's immune system. So they kind of do this conditioning phase where they get them sort of prepped, and then they basically give them someone else's healthy bone marrow, basically. And so it permits them to engraft the healthy bone marrow into their system. And so it's pretty intense because they have to kind of knock them down to get them back, but then their body has to accept it. And so they're pretty fragile for a pretty good section of time. So they begin to produce new marrow within 2 to 4 weeks. And during that time, they are likely on some heavy immunosuppressants so that their body doesn't reject that graft of the new bone marrow. And what's common to see orally from this is like mucositis, mucosal edema, inflammation, and ulceration. So they're going to probably be undergoing a lot of palliative care, and any kind of infections that could have been in their mouth, they would have had those treated prior to. So they'd want to address all of that stuff beforehand.
Something like kind of fairly cyclosporine, but like something like that.
Right. Oh, as far as like a pre-med, if someone like that needed a pre-med.
Like they take medications to help their body not.
Oh, like what's the name?
So like are they, would they take something like that?
They would take like a significant immunosuppressant. Yeah. And now I can't pull the name. No, that's an antibiotic. Isn't that an antibiotic? Don't quiz me on names of medications. I'm not in that group. You're like, I remember that because that has visual enlargement. Yeah, cyclosporin is an antibiotic. Is that what you said? But so we're trying to think of like an immune suppressant. Is that?
Yeah.
Google it. Something will come
No,
up.
it's just like burn is in you.
It does? Oh, shoot. Let's not get on. All right, now. Oh, because you reviewed it yesterday?
Yeah.
Is that on an oral med PowerPoint? Oh, it was? Oh, my word, you guys. There's too much information. Well, we'll look at that. We'll talk about that another day. You can look at it afterwards. Let's keep on this train. Okay, so with the bone marrow transplant, so there's a couple things that can happen for a patient that's undergone this kind of treatment. They can have something called a graft versus host disease. So this is when their body just doesn't want to, it's kind of fighting back. It's like, I don't like this. And so if it happens within the first 100 days after they've received the donor cells, then they can have all of these side effects. You can see that some of these oral manifestations are prevalent. So xerostomia, mucositis, ulcerations, atrophy of the mucosa, opportunistic infections, so they might get more candida. And that's acute. And then chronic would be if it happens after 100 days. And they could have this continue for a while. And this, because it can kind of almost turn into more of like an autoimmune disease disorder. And then it can also affect the oral mucosa, salivary gland dysfunction, esophageal. So it has different manifestations. It just simply would depend on the patient and kind of maybe what their susceptibility is or what part of their body's sort of attacking it. Both types, acute or chronic, can be very serious and it could be potentially fatal. So neither one of them is a good thing to have happen. Okay, so this is just a slide you guys can. This is just talking about getting any kind of work done prior. Getting rid of all potential areas that could cause infection, because basically the patient should go into something like that as healthy orally as they possibly can be, because you just don't want some lingering infection that could just throw it all out of whack. So chemo and bone marrow transplant, the major oral considerations to recap: oral mucositis, neurotoxicity, and that's a little bit more on another slide, but that's when they can have some deep pain, and that's from specifically toxicity from their chemotherapy, can cause some deep pain, and a lot of times it's bilateral, and it can feel like really bad tooth pain too. Infection, of course, of any type could, be fungal or other, bleeding and hemorrhaging. And then salivary gland dysfunction, dental caries, and altered tooth development if they're younger. So we worry about these kind of changes, especially if this is happening in a child that's undergoing chemotherapy. If their teeth are still developing, it can alter their tooth development. So oral considerations: preventing and managing oral complications help to support optimal cancer treatment and enhance patient survival and quality of life. So we don't often think that it, oh, that would make such a big difference. But if somebody is going through cancer treatment and their mouth is one of their biggest problems, that's going to affect their nutrition, which is huge. That's going to affect just their whole outlook on life. I mean, being tired and losing your hair, those are hard. But if your mouth is just on fire and literally it hurts to eat anything, that's huge. And we can help a lot with that, especially with talking to our patients ahead of time about how to prevent severe mucositis, how to improve it, what things to avoid and what things to address. We can be a huge resource for education, especially if we happen to get a patient in our chair who's about to start treatment. And a lot of hygienists too also work for oncologists, or they form relationships to help kind of be a resource, doctors and oncologists. I met a dentist that strictly worked with patients going through chemotherapy and different cancer treatments, and that's the only people he actually saw. So there's different avenues if this is an area that's interesting to you. So mucositis, so chemo may be toxic to the oral mucosa, causing edema, inflammation, and ulcerations. Patients report burning pain, general discomfort, can interfere with talking, swallowing, and then of course that's going to affect their nutrition. Management of this, keeping the oral environment clean and moist is a big part of it. There's different rinses, and you guys saw this in the palliative care. If it's mild mucositis, just like a saline rinse, but just keeping hydrated and using even like a saliva substitute to just keep the tissue moisturized. Controlling secondary infections, keeping up on nutrition as best they can if they supplement with if they can take a supplement of vitamins, or if they can just drink smoothies that have all the veggies in there and the fruit and stuff, and if they're whatever they can stomach or actually get inside them to help with their nutrition. Of course, avoiding alcohol mouthwashes, and then they have other things too that are like topical analgesic rinses and ointments. And if it's bad enough, they might prescribe a systemic analgesic too. This basically just says what the last slide, but there might be a few extra bullet points in this one, but management of mucositis. So neurotoxicity, damage to nerve tissues caused by toxic substances. So the chemotherapy, the plant alkaloids, like if they derive the chemotherapy from a plant alkaloid, that can have really specifically toxic effects on the nerves. And so patients can feel like they have adonogenic pain. And so that can sort of come in waves as it corresponds with their, if they go in once a week for chemotherapy, it might happen for just a little bit right after they get their treatment, and then it subsides again. Infection, again, this is just kind of going over these same points, but if their bone marrow is suppressed or they're immunosuppressed, they could have the bleeding problems or this thrombocytopenia. Risk of developing oral infections, like we said, the bacterial, fungal, and viral. Increased risk of systemic infection, like being septic or sepsis, and then intensifying the mucositis. And then oncologists should decide the safest time to schedule dental hygiene appointments. So we'll talk about this toward the end here. But sometimes it would be, a lot of times it will be before treatment, but we could end up seeing patients during and even after, and there's just different protocols there. They may recommend pre-med, whoever asked about that earlier, especially if they have a central venous catheter or if they're maybe significantly immunosuppressed. And then I don't know, remember where I got this, but I think maybe it's just in Darby and Walsh, but I think they're concerned, like if somebody could have a, like a bacteremia, if they're really immunosuppressed, and you can create your own bacteremia. So they're like, don't brush and floss, which to me almost sounds, the bacteria is just only going to continue, forming. So I don't really quite understand that, but I suppose, there could be very specific situations where maybe they're just simply swabbing the mouth out with like, chlorhexidine or a providone iodine or something just to kill, but they don't want to like get in there and like use a proxy brush and cause bleeding in a bacteremia. So I thought that was kind of interesting. Denture wearers, evaluating frequently, dentures out at night, soak and disinfectant, and remove if irritation occurs. And then the hemorrhaging problem, so the thrombocytopenia, a reduction in the clotting factor or just a low platelet count. And then here's some numbers. I'm not going to test you on these numbers specifically, but basically the oncologist knows when they test, they're probably constantly getting their blood drawn, constantly being evaluated. If they're less than 5,000, whatever that stands for, they're could have increased bleeding during their debridement. So this is something you'd probably, if you would get specific directions from the oncologist. If the bleeding is a concern, then the oncologist would probably say, one way or another, if they could actually even go in for scaling and root planing or debridement. Consult the oncologist as to the patient's blood count. Trauma from improper brushing or an ill-fitting denture could initiate bleeding. The dental procedure is imperative. Platelet support therapy might be necessary, and that's again between the doctor and the oncologist. So salivary gland dysfunction, of course, it increases the risk of dental caries. I don't think I need to spend very much time on this slide at all. We already know that if we don't have a good consistency or quality of saliva, even if the saliva is there, but the quality is not good, like it's thick and ropey and it's just not cleansing and doing the neutralizing that we like, then of course the patient's at risk for caries. So then we have all of our things that we talk to them about. Fluoride trays, where they may be delivered a whole set of fluoride trays before they start their chemotherapy or their radiation therapy, and given instructions on that. Reviewing nutritional things that they need to think about, giving them different suggestions for products like biotin or xylitol, just giving them all that without overwhelming them, but giving them tools that they can have for when they hit that stage where they start to feel the effects of the radiation or the chemotherapy. So radiation uses ionizing radiation from either external source, or sometimes they put in like a little like pill, or not a pill, but like a little, they'll put in a little, I don't know what my word is. I lost the word. Like a little, like, yeah, they put in something, implant, but that's not really what I want to say. I had a different word in my brain, but it went away. But they'll put it in, and they'll have the radiation therapy from within. So they put it like right where the cancer tumor is, or right where they need it to be. Maybe target is the right word. I don't know. It just left me. So examples of cancers that might have head and neck radiation would be, of course, oral cancers, oropharyngeal lymphomas, salivary gland tumors. So those are all areas that they may radiate, and of course, then they're going to have some oral effects from that. A lesion that's less than 1 centimeter may require just surgery or radiation. That's relatively small and superficial. Damage to normal cells may be acute and resolve after therapy. So sometimes people have diminished salivary flow, but then cells regenerate and they do okay. It depends on the person, but it also depends on sort of how intense and for how long and that sort of thing. Other normal cells may not be able to repair themselves. Long-term complications, so that of course we'd see that if it was more intense, we'd see that with their salivary gland dysfunction. So it kind of depends on how much they would be exposed. So acute, so after like the first week, they're gonna, and some of these things are kind of the same on either side, but xerostomia, loss of taste, mucositis, difficulty swallowing, secondary infections, trismus, so sort of just that, we can't very good, the muscle gets kind of spasm, impaired nutrition, hearing loss, fatigue, but then if it's, if they're gonna have chronic problems related to the radiation, then again, they might have that permanent alteration in taste or salivary dysfunction. Oh, this word is a big one, spider veins. Frabile mucosa bleeds easily. You see that sometimes in older adults who are just really systemically compromised. You just like rub your mirror on the inside of their mucosa and it kind of like the petechiae pop up and you can almost even get a little bit of bleeding just from, because it's just so dry and fragile. Continued fungal infections, osteoradionecrosis, rampant caries, and then these other issues down here too, TMJ disorders and altered tooth or jaw development if we're talking about a young person. So the surgery, oh, I had a patient, I've had a couple patients with pretty significant surgeries, but I can think of one from just the recent years, and it's hard. Obviously, psychologically, it's hard, but it's other things that you don't even think about, like just figuring out, you're so used to treating a mouth that is shaped one way, and then all of a sudden you're having to kind of navigate this really kind of totally different landscape. So it's a challenge, and of course the patient has many of their own challenges when it comes to eating. So the primary surgery with lesions, if it's small, they would excise or maybe do some kind of a regression, you know. Yeah.
Sorry, I just wanted to say they just call it a radioactive implant.
That's all it's called. I was like, there must be another term. Thank you.
Looked up internal radiation. Everything is saying
Radiographic implant. Radiographic implant. Thank you. I love all my researchers. Give me the terms, give me the words. Okay. Completely excisable without complications. That would be, of course, ideal, not sensitive to radiation therapy, no involvement of lymph nodes, salivary glands, recurrence of the tumor after radiation. So that's surgery would be like your first go-to if it's pretty much not complicated really, and it's not affecting other areas. Complications from surgery, of course, are going to be multifold, and it's going to depend on how significant how much of the mandible had to be resected is the term. I keep wanting to say regressed, but they resect it or they take it away, how much they have to take away. So the patient is going to have to deal with physical complications like recurrent infections, airway obstructions. I mean, just you think about everything about the way your mandible helps your tongue stay in a certain position. All of a sudden you take away all this structure and you're just left with all sorts of different things. So necrosis, impairment of swallowing can affect hearing, vision, perhaps, depending on where the removal of the of what part of their face had to be removed, affecting speech, obviously smell, compromised nutrition, inability to swallow. Am I hearing music? You're fine. I'm like, I hear pretty music. You're fine.
Some kids bracket below.
Yeah. But anyway, yeah, so swallowing, drooling, and then of course there's the whole psychosocial, just dealing with all, like the anger, the, just the feeling of having to adapt to a whole different way of living, really. So what patients can use perhaps to manage some of these complications. We assess for oral irritation. A lot of times they'll have a very specially made like denture or some kind of an obturator or something that might be specially designed just, for their shape of what their mouth is now shaped like. So we have to kind of help them with figuring out, how to keep it clean and all these different watching for sores and things like that. So assess for oral irritation and comfort, empathetic listening and stress reduction. It's amazing once you've had a patient that sort of has gone through the whole process and it's been a while, and every patient is different, but this one gentleman that he had a pretty big section of his mandible taken out, and so it just gave that real collapsed look. And he had all kinds of issues with the thickening of his saliva and just having to like sit up differently and like all these things. And I just kind of had to let him sort of guide me with what he could tolerate, because I only think I saw him twice, and then he saw the doctor a lot, and then he saw the other hygienist. So I didn't see him like every 3 months, but you just kind of have to, because it's like a whole new experience. You just don't see patients like that every day. So you just have to kind of, but you think about all the other things that, that kind of roll into any patient with complications, keeping the oral cavity clean, making sure that, things aren't, irritations aren't hanging around, that patients are addressing any of these things, making some modifications with their oral hygiene tools to help them think kind of creatively and how to keep things clean. So could possibly be just using some of these swabs in some areas, rinsing, oral irrigation. You just kind of have to think about what will work best for that patient in their situation. That's their ability to wear their prosthesis. We have to think about the different types of tissues that might be there, more delicate tissues, especially if the mouth is dry. Maxillary difficulties after surgery. Patients, it's the same sort of with the oral facial clefts, that change in the voice, perhaps the nasal voice quality, thickened nasal and sinus secretions if the surgery affected the sinus area as well. We already talked about swallowing and mastication difficulties. Mandibular difficulties may need additional surgical procedures to help with function. So sometimes they have, it just came to me. My patient that I had, he actually had part of his rib. So they have sometimes they go through a series of surgeries. So it's like, it's not over once they have this one surgery. So he had some reconstructive surgery where they actually used a part of his rib to try and build back his mandible. I know, it's crazy. So mandible, let's see, may need additional surgical procedures to release the tongue. Let me get rid of my pictures in the way here. From the floor of the mouth, graft in skin, create a vestibule for saliva to pool. I mean, you don't think about that could be just wiped out, and then they're just drooling constantly, so they will do some reconstructive surgery, allow for the extension of a denture for the phalanges. So they might have to just come up with some creative, plastic surgery to allow them to return to some function, some regular function. 7 minutes and I still have 8 slides. Okay, bisphosphonates and osteonecrosis. So a patient could have osteonecrosis from taking the IV bisphosphonates, which cancer patients can be given this. And oh my gosh, I can't think of exactly, it has to do with their calcium, in their blood levels of calcium, but they'll be given it oftentimes IV. And so doctors make sure that they have had all their extractions. We don't want dentures to rub. They can't have an implant, 5 years later, because they could have this osteonecrosis where they just it'll fail and they can't get that area to heal. Then the other term to know the difference is the radiosteonecrosis. So one is from radiation that kind of kills the bone and makes it so that the osteoclasts you don't get bone turnover and healing of the bone. Or the other reason is because of the bisphosphonates, which also does the same thing. It suppresses the osteoclasts. It makes it so your bone doesn't kind of turn over and the cells don't turn over. And and that healing is compromised. So I think I'm going to just skip that assessment. This is a little bit about assessing them when you're taking the health history and talking to them. You can read through that. And I just want to quickly get through this before and after. So some major before things that you want to think about here is a lot of education, tobacco and alcohol cessation, collaborate and give patients some sense of control. They're probably feeling very overwhelmed with a lot of the information that they have. So you want to listen and then provide them some information. And you could even follow up with them, like give them a call like a week or two later and say, hey, I know that you're going to be starting some heavy treatments, and I just wanted to know if you have any questions. We talked about a lot of stuff about, you know, keeping your mouth healthy while you go through your cancer treatment, but have you had any time to reflect back on it, and do you have any questions? Just a really great strategy for someone who's just feeling bombarded with like medical information. Before, nutritional counseling, fluoride, so perhaps fabricating trays, talking to them about what diets to avoid in order to minimize any negative effects from the cancer treatments. During, all dental treatments finished before entering into cancer therapy is the typical thing that most doctors would want to do. They'd want to get you as good as you can be before you start all of that immunosuppressive and kind of difficult. And then we talked about the management there. Your patient, I say that your patient is the expert because they're the ones, every cancer treatment is different, and they're the ones that have been getting all this information. So allow them to kind of share, and then you can always call their oncologist too if you have more questions. And having an empathetic ear. So if they do come in, we might have to give them more information, some more counseling for dietary and nutritional counseling. And then afterwards, most oral manifestations resolve, of course, not all, but most, and then necessary dental treatments only after consultation with oncologists to assess immune status, pre-medication if they need it, or platelet support. So if it's been really recent since they went through it, unless they come bouncing in just saying like, yeah, I feel great, I'm in the clear, blah, 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 you know, but if they've had something serious and you know, it's, you know, you might need to touch base with their oncologist. So read through that just in case I'm going too fast and saying, I don't want you guys to miss anything. After radiation, lifelong frequent dental visits for maintenance, especially if they have some salivary dysfunction that's permanent. They're always going to have to be a little bit more on the ball with their oral hygiene. And then this is summarizing Pacific University's guidelines for chemotherapy, possible antibiotic pre-medication required, control spontaneous bleeding with gauze, topical fluoride for caries, xerostomia management. This just sums it up nicely. Radiation, brush with very soft toothbrush, chlorhexidine rinse, topical anesthetic, management, daily fluoride management of. That's just kind of a good overview of some of the most pertinent things that you're going to have to think about when thinking about patients with chemotherapy or radiation therapy. And that's it. We did it 2 minutes early. All right. Thank you guys. So you're good to go. And then we'll see you next week. And I'll get the other one, the substance abuse. I'll get that one up on Moodle tomorrow because I will work from home tomorrow.